Hi, everybody. Thank you for joining us for what is our last of something close to 50 or so virtual roundtables over the last couple of years um, on telehealth and virtual services for the MCH population. So we are excited to have May from the Center for Connected Health Policy with us. Can you guys hear the dog that's barking in my background? I'm like interrupting myself. Great. Okay, we can cut this part out. Dog losing its mind in my hallway. And we're excited to have May from the Center for Connected Health Policy join us today to kind of talk about what happens after the public health emergency expires, both at the federal level where it's still in effect, and at the jurisdictional level where many of them have been allowed to lapse. I think a couple or maybe at least partially still in place, and just kind of where things stand and where folks can go. And we're recording this, and then at the end we'll have the opportunity for you guys to ask questions of us and of May, and kind of to go from there, because I know you guys are both, I think, with Eddie programs, so we can really dive into that if we want, and we could do whatever we want because this is our show. So as usual, we do thank and acknowledge CDC for their support of this work, and note that nothing we say is representative of the federal government or HHS or CDC. All right, and from there, I will pass it off to May. Thanks.
Thank you, and thank you everyone for being here today. Since we all are a small group, I'm actually fine if you want to stop me in my middle of the presentation, if you have a clarifying question or something occurs to you. I think we should really have a dialogue about this, and that should work with such a few amount of people here. But wanted to thank AMCHIP for this opportunity to do these roundtables with you. Been with you guys for a couple of years here, and it's been really interesting to hear what you've been doing, your individual programs around telehealth. Working on the policy end, I am sometimes removed from the actual delivery of services, so I always try to just keep in touch with where on that aspect, just because I always say somebody like a policy person can write a beautiful piece of legislation, but if it doesn't work when you implement it on people providing services and the patient receiving those services, it's useless. So it's good to hear back from folks on what are the issues that need to be addressed, and how can they be best addressed so it works for everybody. So I think also you will get a copy of the PowerPoint, so don't feel pressured because I've got a lot of text on some of the slides and I'm not going to read everything, and I might skip through it really quickly. You get a copy of it, so don't worry about that. And also I need to point out some disclaimers here. I'm not providing you with legal advice. It is strictly for informational purposes. Always consult with legal counsel if you want a formal legal opinion. Also, if I happen to mention a company or some type of product, know that neither I nor CCHP has any type of relationship or affiliation or financial arrangement with such an organization. So anybody who has heard me talk probably in the last 2 years have seen the slide because I use it all the time. It's a nice overview slide of just very in general the areas that telehealth policy changes were made in response to COVID-19. Now, the majority of these changes when they were first implemented were temporary. And as Sabra has mentioned, some of the states' public health emergencies have ended. So states are in various positions here. Some of them had made some of their temporary telehealth policy changes permanent, or they've let them lapse. Or some of them have even extended them, saying we'll make a final decision in 2023 because we want to gather more data and evidence to help us in that decision. But as you see what happened on the federal and the state level, there's a lot of common areas that they touched upon or common issues that they address, such as, the type of provider who can provide services via telehealth, the type of services that they'll cover and reimburse for, the type of modality used. And then there were other issues that were specifically federal or state issues to address, such as HIPAA on the federal level and licensing on the state level. But, commonalities, at least for the questions that came up, different approaches on what they took to address those particular questions. Now, I'm going to start with the federal level. I know most of you are probably more interested in what's going on the state level, but it's still really important to understand what's going on the federal level, because for some states, their telehealth temporary policies were tied to the federal public health emergency as opposed to the state public health emergency. So you could have had a state declared a state of emergency on the state level, but then they may have said, oh, but for our telehealth policies, they're tied specifically to the federal public health emergency. California is a good example of that. They specifically said their telehealth policies were tied to the federal public health emergency, not the state one. So, and there were some states that other states were like that as well too. So that's one of the reasons why to pay attention to what's going on the federal level with telehealth. But another reason is that there's always that trickle down effect or that copycat effect of how the federal government may decide on a policy and you have a state basically replicating it. And that's important to know because there were some states going into the pandemic that didn't really have a lot of established telehealth policy. So they just mirrored what the feds did because that was there readily available for them. It's even more important now to keep an eye on that because now the feds are, well, what happened with COVID-19, there were some areas in telehealth policy that really weren't sort of addressed by the majority of states or really by anyone going into the pandemic. For example, the use of audio only to provide services. If you spoken to anybody before the pandemic and said, oh, does this fall underneath telehealth? And say, no, there's actually a lot of states that say explicitly it's not part of telehealth. But as most of us know, when the pandemic started, there was a realization not everybody would have access to live video, so they needed to allow audio only to be used. Now people are trying to figure out, well, what do we do with this audio only? We haven't had to really consider this policy beforehand. They're kind of looking around, seeing like, well, who's doing what? What do we do for? What do we allow it to be used for? And we also see the feds making decisions on that as well too. So that's why I say like it's kind of really important to like look at the federal government, what they're doing, even though you're so concentrated in state, there could be that trickle down effect or that copycat effect, and it could be like replicated on the state level. So what are the feds doing? What have they been making permanent as far as like their telehealth waivers? What are they doing? Right now, we're in a state of where it feels like on the federal level, they're prepping themselves for the end of the public health emergency. The telehealth temporary policies, the waivers on the federal level are tied to that public health emergency and like when that ends. So we're starting to see the federal government kind of set the stage of like, what's this going to look like once we decide that public health emergency is over? And they do it through three channels. They either will do it through legislation, they'll do it through administrative action, and that's usually through CMS, Center for Medicare and Medicaid Services, because a lot of the federal telehealth policy that's established, it's concentrated in that Medicare program. So they're doing things on that scale. And then there are guidances and reports. And these are usually like other departments where what they oversee have an impact on the use of telehealth, though they may not necessarily have anything specifically addressing telehealth. And one of those sort of areas is, for example, HIPAA, which is overseen by the Office of Civil Rights. So there's nothing in HIPAA specific to telehealth, but it has it's an important player, policy issue in the telehealth field. So they are doing things as well too. So a couple things that they're doing is really interesting on the federal level. Unlike states, they have not made any of the temporary telehealth policies that were done in response to COVID. They haven't made any of that permanent. They've done other stuff. So they've done other stuff around telehealth policy that will become a permanent policy, but they haven't like really addressed any of like the temporary policy and said, okay, we're going to make that like a permanent policy going forward. What they did was they expanded the ability to provide mental health services underneath Medicare when you use telehealth. Now, for those who aren't familiar, in the Medicare program, when you're using telehealth to provide services, the patient has to be in a specific type of location. And that location has to meet a geographical requirement, and it also has to meet a site, the type of building requirement as well. And it's a very specific list of sites like doctors' offices, hospitals, clinics that they have. And then a geographical element there, it's a very specific definition of an eligible type of geographic location. They say it's a rural area, and there's a specific definition of what they mean by rural. Well, Congress decided at the end of 2020, when they passed the Consolidated Appropriations Act, they decided, well, we're at least for mental health services, we're going to like set aside those two rules if certain conditions are met. And one of those big conditions is that if there is an in-person visit with a telehealth provider at least 6 months before those telehealth services are being provided. So that kind of actually, at first when you're like, oh, great, they're going to use telehealth and not have these like location restrictions, but then you hear the condition, that actually really narrows down the scope, or like how broad that policy is, because now you have this actual, I need to go see this telehealth provider in person. Well, what if your telehealth provider is like 200 miles away? That's the reason you're using telehealth, is so you don't have to travel the 200 miles, but you are requiring like at least this one in-person visit. That could still create difficulties for somebody who has transportation issues. So it was like, it was an expansion, but it wasn't broad or expansive as some thought. So that was like the only really kind of permanent policy that they put in place. And they allowed like another type of site to be an eligible site where a patient could be. It's a rural emergency hospital. So it was actually a new classification that they did. So those were the kind of only permanent policies that they've done. The other thing that they did through legislation, and through a budget act this year, is that they said, okay, when the public health emergency is over, we're not going to make any policies permanent, but we're going to create this grace period. So once the public health emergency is over, we're going to create a grace period of 151 days for some of those temporary policies. Oh, and by the way, what we did in 2020 with like the mental health stuff and requiring that in-person visit, we're going to delay that as well during that 151-day grace period. So 151 grace day period, we're kind of operating the way we were during the pandemic. And I say kinda, it's because they did not allow like all of the telehealth temporary waivers to take place or go forward in the 151 days. One example is the type of providers that they allowed to provide services via telehealth in the Medicare program and get reimbursed. They had basically said, like during this public health emergency, CMS basically said, if you're an eligible provider and you can provide one of the services that we allow to be provided via telehealth, we're going to pay for you. So they didn't like really didn't say like it's only these types of providers. They just basically said if you're an eligible provider, go for it. What the extension, the 151-day grace period said was, well, we're only going to allow that for federally qualified health centers, rural health clinics, speech language pathologists, audiologists, PTs, and OTs. So, everybody else that is like on that Medicare list or Medicare eligible providers, they won't get that. They won't be able to do telehealth in the 151-day grace period unless they were on the original sort of pre-pandemic list that they allow, which is like a very small list. It's only like about 10 types of providers. So that's one thing that we know is going to happen. Once the PHE is declared over, we've got this 151-day grace period, but we're not going to see all the relaxations that we saw during the pandemic. The other way of, doing more permanent policies or setting the stage for this coming right after the PHE, whether we're in the grace period or not, is through the physician fee schedule. Now, basically what this is that each year CMS comes out with their proposals of policies for the following year for Medicare. And they put it out in something called the physician fee schedule. They do a proposal sometime in the summer, like around July. The public has 60 days to like provide comments and queries on that. And then CMS has to respond to it. And then they finalize the policies in November. Sometimes they pushed it out to December. And unless the policies are dated for a specific date, they usually go into effect January 1st the following year. This is usually where they put a lot of like telehealth stuff, of the stuff that they can't do administratively. There's some stuff that's in federal law, you got to wait for Congress, but what they can do administratively, they usually stick in a physician fee schedule and like go about it that way. So what they did was they said, some of those temporary services that we allowed during COVID to be done via telehealth, and they're not on our permanent telehealth list, we're going to keep some of those services around. We put in a bucket called category 3. And we're going to allow providers to provide those services until the end of 2023. So at least like providers know there's going to be these list of temporary services, not all of them, not all that was allowed during COVID-19, but there's some of them that at least they know no matter what happens, if the public health emergency is declared over tomorrow, it's going to stick around until the end of 2023. So that also outstrips the grace period as well, too. If the grace period, ends 151 days before the end of 2023. The other thing that they said was, for our permanent policy going forward, we're going to allow audio only to be used to provide mental health services. Now, this one is big because, as I said earlier, before the pandemic, audio only really wasn't considered telehealth. It wasn't considered a modality of providing services. But now you have CMS saying, well, for mental health services, we're going to allow it if certain conditions are met. And some of their conditions really kind of mirror what was in the Consolidated Appropriation Act, that, oh, you need to have a visit in person with the telehealth provider before you can do these services. So that was big too. Now, the other big thing that they did was they redefined what a mental health visit meant, federally qualified health centers and rural health clinics. And what the new definition would be is that a mental health visit also includes providing those services via live video and audio only. Well, that's great. So they've made FQHCs and RHCs telehealth providers. No, they haven't, because they can't. So in federal law, there's very specific statute that says these are the type of providers can provide services via telehealth underneath the Medicare program and get paid for it. That is in federal law. It would require Congress to actually change that, and FQHCs and RHCs aren't on that list. So you ask, how did they do this, and why isn't this considered telehealth, or why aren't they considered telehealth providers? It's because CMS redefined a term. They redefined a term, the mental health visit, what that means for these particular entities. So they're not telehealth providers. They are still merely providing this visit that they're supposed to provide, that just happens to be able to use these two forms of technology. So that means FQHCs and RHCs aren't being treated as providing telehealth services. They're merely providing a mental health visit. What that also means is that doesn't have all the restrictions that telehealth has underneath the Medicare program. So that rural restriction of you need to be in this rural area for these mental health visits, that's not going to apply to them because they're not using telehealth. They're not telehealth providers. They are simply providing a mental health visit, which they can provide, or they're supposed to provide as FQHCs and RHCs. And that definition happens to have underneath it the use of technology to provide services. So that was like another permanent policy. Now, all this to say is we go into now what they have as current proposals for 2023. And a lot of this is like really clear up language of what they did. So basically, there was the whole question of like, okay, so we know that there's going to be some of these COVID policies that stick around on the federal level after the PHE during the 151-day grace period. But we also know CMS did a bunch of other stuff administratively. What happens now? And CMS is saying, okay, well, what happens now is that our whole thing about mental health and providing via audio only, we're going to put a pause on that during the grace period. That's not going to kick in as well either because we're in the grace period. We're also, clarifying that those the full list of temporary services that you can provide during the pandemic via telehealth, that full list is going to stick around. So that full list will stick around during the 151-day grace period. So again, this was like, there's like nothing really kind of earth-shattering that they were offering, but they were clarifying like a few things of like that were still kind of fuzzy after what Congress did in the Budget Act, like that we weren't quite sure. Well, does this mean this also sticks around or doesn't it? And now they're saying like, yes, some of these things will stick around as well too. This is just like a couple of other things that they directed as well too. So I'm just going to skip over these because that's like very in the weeds. Now, the other thing that can happen are kind of guidances and reports. These are from like other agencies that maybe they have issued to like clarify things. And there's been a couple of them that have come out in recent months around HIPAA and also around the American Disabilities Act. So prior to COVID-19, these were kind of, I don't want to say overlooked, but they weren't really addressed to a great extent in telehealth. Because for one thing, for HIPAA, there's nothing specific to telehealth in there for HIPAA. So it's always been kind of a gray area of like, well, what do you do for telehealth? It's like you try to like still meet your HIPAA requirements as best as possible, knowing that you're using technology to provide these services. So they've come out with at least a guidance on, how to address it and also if you're using like audio only. The other thing is when you're talking about the ADA, which I would say was, very bad in the telehealth field to do before the pandemic is that not a lot of attention was really paid to providing services via telehealth to communities, a population with a disability. Like, how do you do that with telehealth? I don't say it was totally ignored because there were definitely people who were paying attention to it. But I think because telehealth wasn't as widely used, it just didn't bubble up to the surface as much as this, issue that needs to be addressed more widely. But there has been guidance put out by HHS and OCR regarding, information on like using telehealth and, addressing the needs of certain populations as well too. And then the other big thing is around fraud or misuse of telehealth in Medicare or in Medicaid programs. That's like a big thing with that you hear from policymakers is like, oh, if we expand these policies, aren't we opening it up for more fraud and abuse and et cetera? And the Office of the Inspector General is coming out with a report. They said at the end of the summer, but possibly in September regarding fraud and misuse in Medicare. Up to this point, they have said they actually haven't found telehealth fraud. They found telemarketing fraud, but not necessarily telehealth fraud in the Medicare program. But then again, that information that they had kind of goes up to the pandemic. They were still studying what happens in the pandemic. So they said, like, up till the pandemic, we didn't really find anything, but I don't know if that's going to change if we dig into the data during the pandemic. So that's also a thing to keep an eye on, especially the fraud one, because I hear this a lot from state policymakers, like, well, what about fraud? So, that if the OIG comes out with something favorable, that's always something like advocates can point to of like Medicare, CMS, they didn't really find anything. So what makes you think you're going to find it in Medicaid as well too? So I just want to point those out. Oh, so what's going on in the state level? I know this impacts you more closely or is more close to home. And as I said earlier, states are kind of at various levels of where they are with like their telehealth policies. Some of them, the public health emergencies lapsed or their temporary waivers have lapsed, and they've gone back to kind of status quo before the pandemic of like, this is what we're dealing with telehealth in our state. Others have like adopted things as permanent policies, but they may not necessarily have adopted the full range of policies that they had floating around during the pandemic. And then others still are in that, well, we're going to wait. So we passed legislation to keep stuff around until 2023 or 2024 until we can get more information. So states that have done that, for example, have been like Maryland and Connecticut. Connecticut just recently extended some of their stuff out to 2024. They had it in 2023, but now they've extended a couple of things out to 2024. So this slide kind of gives you an overview, at least for modality, what's allowed in fee-for-service side of things for Medicaid programs. And even before the pandemic, that live video one, not a big shocker. It was like always kind of like that. Store for and route patient monitoring have gained a little bit, but the big thing is, again, that audio only. I didn't even have that as an element on the slide before the pandemic when I was doing presentations. It's just simply because very few states allowed it, or if they allowed it, it was like for very, very narrow or specific things. So it was almost kind of like not worth it to track it because it was just sort of like this perhaps odd little element, or it was like in a very specific circumstances. But look at it now, almost half the state have some type of policy regarding audio only in their fee for service in their Medicaid programs. Now, if you dig deep into that though, they're again, very specific policies. And this is where kind of like what's going on the federal level is mirroring at least, and it's kind of chicken and the egg, who came first with this idea, or did they all just kind of come to it at the same time? A lot of those audio only policies though, are related to mental and behavioral health, and just allowing audio only to be used and reimbursed for the provision of those services. So that's what we're seeing on the federal level. We're also seeing that mirrored on the state level. Now, looking at the timing, they all kind of seem to have come to that same conclusion, or that reached that at around the same time. And that is partially because I always call mental and behavioral health the gateway specialty for telehealth, because it's like the specialty that most people can understand. It's like, oh, you can't touch anyone with telehealth. How does it work? It's like, well, mental and behavioral health, you probably shouldn't be touching them during your session. So then they get it. They're like, oh, okay, that video makes sense there. I think that was like more readily acceptable to a lot of policymakers in that, yeah, you can do that through audio only. And also in speaking with a lot of practitioners, they said there's actually a lot I can do through audio only if I'm like a therapist or a psychiatrist. That actually really works very well. Less so for maybe some of those specialties where you do need like a visualization of the patient, but audio only does work. And where we are seeing it is, again, mental and behavioral health sort of like leading the way, or at least is like the more acceptable specialty for policymakers. This has been interesting as well. So on the state level, it's not just about Medicaid, it's also about what commercial payers do too. And the majority of states have private payer laws. So these are laws that states tell commercial payers, this is what you got to do around telehealth. Now, these all vary. They vary from one extreme of a state law that says you can reimburse telehealth if you want to, health plan, Florida, all the way to a state that says, well, health plan, you shall reimburse for telehealth the same way you would have had it been provided in person. And by the way, you will pay the provider the same amount you would have if they had done it in person. Hello, Delaware. And then everybody else kind of like falls in between on what they do. What is really interesting is what's in that blue box. I'm saying that 21 states have payment parity. And what payment parity is like a mandate to health plans saying like, you will pay them the same amount, regardless of whether it was in person or telehealth. Before the pandemic, there were only 6 states that did that. Now, 2.5 years later, we're seeing almost half the states doing it. So an increase of like 19 states having that explicitness in there. So that's been like kind of interesting to see. It's like we're not seeing the overall numbers shift too much. It's still like, it's always been around that basically 44, if you include DC, 44 side of things, but it's like the policies in between, like that they've been tinkering with, saying like, you got to pay the same amount. So what do we see? We haven't done sort of like a roundup for 2022 because not all the legislative sessions are over, so we're not quite sure. But basically what it fell down to last year were practically almost all states passed some type of bill related to telehealth. There were over 200 of them passed, usually around the private payer reimbursement, Medicaid, and cross-state licensing. I haven't talked about that yet. That's another huge issue regarding telehealth, and also what happens after the pandemic is that licensing issue. Which basically is that you need to be licensed in the state the patient's in. So if you're a provider outside of the state and you don't have a license in there, for the most part, most states, you're going to be acting illegally. You need to get licensed from them. During the pandemic, at the height of it, there were states saying like, we're going to do a waiver, but a lot of those licensing waivers have just already expired. So we are back to that state of you better get a license. There have been like sort of different ways to address that there have been licensure compacts, but that requires the state to join it, and the state hasn't joined it. And or if you're dealing with a state that's not part of a compact, then that doesn't really help you too much. Interestingly, there have been like a couple of states that created registries. So Florida was actually the first one where they said, if you get on the registry, you don't have to get a Florida license. So that's been interesting to see. That's kind of been like the compact alternative, but it hasn't quite taken off. I think there's only been about 2 or 3 states that have done that. So it hasn't quite taken off to the level of compacts, where compacts are profession specific. So there's like a doctor's compact, there's a nurse's compact, there's a PT compact, there's an OT compact, there's a speech language pathologist compact, there's a psychologist compact, there's an EMS compact. There's a lot of compacts out there. There's also a social worker compact, but I don't think they've hit like the minimum number of states to actually activate yet. So that's been like really the popular way of dealing with like the licensure issue now. But it's definitely been an elevated policy that people have really focused in on, including the federal government. Now, licensure is in the state purview, so it's not something the feds can actually dictate, but you're getting them kind of pushing a little bit. So you'll see bills come out. There are a couple of bills that have been introduced where they're addressing licensing, but they'll say something, well, during when there's a public health emergency, then this kicks in, that type of way. So they've gone that route, but they've kind of been pushing around, and it's really been interesting. Like during the beginning of the pandemic, I got so many phone calls from congressional members or state lawmakers or their staff saying like, I've got this situation about licensing. Is it true? And it was usually like, my kid or my constituent's kid or my staffer's kid is going away to college, or they've been sent home from college, but they still want to access student health. But they're being told that licensure is an issue. It's like, well, yeah, they're in two different states. It's an issue. So that's been interesting to see. Is like, oh, okay, well, you've seen like a direct consequence of that now. So it's like up on your radar. So other things that have been impacting, or that we've seen like in legislation, at least for 2021, is around online prescribing. Again, a big issue. Controlled substances prescribing, and where telehealth is concerned, that's federal law. That's in the federal realm to deal with. But everything else, if it's not a controlled substance, that comes under the state law. And a lot of states do address like the use of telehealth for that. They've basically, going into the pandemic, they were saying like, well, you can use live video to do this and like prescribe if you feel comfortable that you've got all the information you need. But they were saying things but it was basically, that's it. It's live video. It can't be one of the other modalities. We're starting to see them kind of consider, it's like, well, should we allow maybe audio only, or should we allow like an asynchronous type of like interaction to do that? And part of that is, addressing, I think people are finally realizing there's some healthcare provider shortages out there, especially if you're talking about things like mental and behavioral health. It's like, you got to kind of make it easier, because you can't force people to move to like this particular location to provide these health services. So what are you going to do? Got to try to make them available in some way. And then also there's specific language that we saw that was allowing certain professions to use telehealth. Now, before the pandemic, there was no law against using telehealth, but you know how, especially since we're such a lawsuit minded like society here in America, I think people are like, unless I see it written down in black and white, I'm not going to do it. So even though there's nothing in the books that says I can't do it, I kind of want something on the books that says I can do it. So there was sort of like more explicit language of like, because there may have been just sort of like this vague reference of like, bro, providers are doctors, nurses, and physical therapists. And then, but then you have an OT saying like, well, what about OT? It's not in the list. So there's like been more specific language about that we've seen in legislation. So what are we seeing now? We don't have the numbers for what's going on in 2022, but basically what we're seeing are very similar to what we saw in 2021. What do you do after the PHE? What do you do around Medicaid and like, commercial payers? Like, what are the changes there? Interestingly, a lot of direction too on documentation record keeping. This is like one of those areas that it was sort of like vagueness before the pandemic, sort of like, well, you would just follow HIPAA and like your usual documentation. And going into the pandemic, when so many new people are using telehealth, there were questions of like, what am I supposed to do? What am I supposed to do? And they were trying to do it in a hurry because they needed to stand up their programs in a hurry. So there's like been more explicit direction on like what type of record keeping and documentation you need to have. Again, we're probably addressing wanting that sort of concrete. If it's not in writing, I'm not trusting in what you're telling me. So I want to see it in writing. And then also telehealth standards for various professions as well too. And this is, again, goes back to before the pandemic, you had like maybe some professions that didn't necessarily have guidelines for their professionals on how to use telehealth, whereas you had other ones who had like very explicit guidelines, like the dermatologists. They've been doing this for like years. So they've like, had it all the way down. It's like, this is kind of how you would conduct this type of like visit type of thing. So like more sort of like telehealth instructions for their licensees. So Sabra and I have, asked me and said, to cover this and also to talk about this, because I guess it's been an interest of folks of like, what can you do? Because there's all these telehealth policy decisions that are being made. Where's it going? Not only where is it going, but how can you influence it to make sure that the policies that have benefited your populations or your constituents the most stick around at least, or in some form remain, so they can continue to help out your people there. So on the federal level, the most active folks have been organizations like the American Telemedicine Association, Alliance for Connected Care. They've really been pushing on those Medicare temporary policies. Now, some of you may have heard this. There has been a bill to extend those until I think it was like in 2024. It's the Liz Cheney bill. So that passed the House. So that, I think they may have been doing her a favor there. But you never know. So you never know. anyway, so that has been moving forward. I kind of think if they're going to do something permanent, they would follow kind of their more typical MO, in that if there's a bigger bill of something, they'll stick it in there or stick stuff in there. Like what I was talking about earlier, it was in the Consolidated Appropriation Act and the budget bill. So I kind of think they would like put it in there, and not necessarily, they typically don't do like a telehealth single bill and pass that through Congress. So even though something made it out of the House, I don't know if it's really going to go anywhere there. Also, a lot of advocacy on the federal level, and probably on the state level as well too, has been sort of more issue based. They're saying, well, if you're not going to do all of these temporary policies, at least do it for X, maybe for mental health. There's been a lot of interest in telehealth and maternal and child health as well too. There's been a lot of funding put into budgets where they talk about maternal and child health, and telehealth might be an element in there. So I don't know how much it will go towards telehealth, but they would have it like in a list of elements of like, oh, to look at programs that can do, you know, X, Y, and Z, and telehealth may be like one of the things listed as well too. On the state level, what's been interesting to see is like the different groups who have been advocating for extending out these telehealth waivers or making them permanent. So they've been more diverse than what we've seen before the pandemic. Before the pandemic, they were usually, for the most part, kind of like healthcare groups or technology groups. And now you're seeing like sort of more broader healthcare groups doing this. Like before, in healthcare groups, it was like, you know, medical boards or medical associations or primary health clinics that were kind of active. Now you're seeing more sort of patient level, like representative type of groups, like, you know, people representing kids, people representing seniors, people representing maybe certain segments of the population, like college students. Like I'm in California and I've had like a couple of groups approach me, and they represent like, you know, youth or college students who are interested in a specific issue or have like a specific need, such as maybe like some type of mental health need. So you're seeing like more diverse groups like getting engaged around telehealth policy because they've experienced it now in the during the pandemic. So when people asked me and they said like, you know, what can we do? And I said, reach out to some of these groups, because there have been a lot of people affected by telehealth and they may not understand like, you know, what they need to do in order to like keep some of these benefits that they've seen during the pandemic around too. And they may be interested in doing it. So an example that I have here is like what we do in California. So CCHP runs a group called the California Telehealth Policy Coalition. It's over 150 state and national groups who are involved in it. We've been in existence for 12 years. We've been doing this for 12 years. And we really started off as more sort of information sharing. Really, the genesis of this group was around a bill that CCHP was acting as a technical advisor on, and a couple of groups approached us and said, hey, can you just keep us up to date on what's going on with that bill? We said, sure. And then those meetings, you know, spun from like 5 groups who are supporting the bill to suddenly now we're over 150 groups, and they're very diverse. I look at who's in the coalition as memberships, and they're open meetings, and we accept anybody wants to attend, definitely can. And they range from telehealth technology vendors to, you know, groups like a Teledoc or Hims and Hers who have like an interest in telehealth, to state associations like the Primary Care Association in California, the Medical Association in California, to health plans, to specific patient groups. We have AARP California as members. We also have different profession groups like marriage and family therapists, just a wide range of folks. And we even allow state people to come in, like either their legislative staff or they work for a department. We say like, you can come in and listen in on the meeting. It might help you. You might get an idea of like, because there's such diverse groups represented, what people are feeling in the state and what they are seeing as a need there as well too. So you don't necessarily have to do it the way California has done it, but I am saying that it is probably a good idea to reach out to a broad range of folks too, because I have found that has been beneficial is that when you have all these different interest groups suddenly saying like, we want this one thing, it's been a lot easier getting that one thing to pass or getting that one thing through, because they're like, either they connect with a group and say like, oh yeah, you guys do great work, or I know you, or I'm interested in your issue and you're saying this is going to help. Or it makes them feel better in that, oh, they got so many people, nobody's going to like oppose this. And I don't have to face like, criticism as I'm like trying to shepherd this bill through the process. So that's like been sort of like the other benefit of like having such a diverse group of folks or voices saying like they support something. So this is just, again, my observations, what's worked in the past is like that engagement by a variety of partners. Also frequent and early engagement with program officers. We've managed in California to build a pretty good relationship with the Department of Healthcare Services, only because we reached out to them ahead of time, said like, we're thinking of doing this. What's your reaction to it? And while we may not agree, they may say like, we're horrified by that. Where we may not agree, they appreciated that early sort of warning and our explanation like, well, we're doing this because of X. We would love to work this out with you. We're not able to, we're still going to do it though. So, but they've appreciated that early warning and awareness of what's coming down the pipeline. And then educating policymakers. I cannot stress this enough because it is just so surprising to me, like even now, how sometimes policymakers may not know certain things. So especially if you have like a particular interest or a particular issue, there's a good chance the policymaker just may not be aware of it or the ins and outs. So I keep saying I get surprised about how there's actually a lot of policymakers that don't really know kind of like almost the basics of what I would consider of the licensure issue. So it just I turned to staff at one point. I said, am I talking for, I'm like, I thought everybody knew this. And they're like, well, no, probably not. So yeah, we may have to step it back because they're not immersed in it all the time. So that's why I say like educating them is really like the best way, and really the best person to educate them or to like bring us the item to their attention is either if you are a provider or you're a patient. Because me talking to them only gets so far as a policy person. They just kind of nod politely and just go, yeah, yeah, yeah. But if they're hearing it from somebody who is specifically impacted by it, either in that they're providing the service or they're receiving the services, that resonates so much more with policymakers as well too. So that's sort of like the other tip that I've seen has worked more effectively than some strategies. And that's about it. That is your quick overview. The only other bit that I can add for you is that we did get another renewal in the public health emergency. So we on the federal level. So it is good through October 15th, I think is the date, mid-October. There are rumors that there's going to be one more renewal. So it's looking like it's possibly going in through 2023, at least early part of 2023. Again, these are rumors, so don't take it as gospel from me, but there were rumors that it may be renewed partially to get them through the midterms on that, but also, just to ensure states have enough time to like unravel their policies and everything. So, but yeah, I thought it was going to end in October. I'm like, oh, there's a chance maybe towards the end of the year, and it's kind of looking like we may get that one more renewal of it. So that's about it. I'm going to stop sharing there and, happy to take any questions.